I'm going to take you through kind of a broad overview of stroke prevention issues, acute management issues, and then we're going to have Dr. Gooding kind of tell us about the cutting edge in terms of interventional stroke care. So first of all, to define the problem, stroke is the most common long-term source of adult neurologic disability or adult disability in the United States and remains a key leading cause of death, third leading cause of death at this point. And you can see that there are lots of new strokes a year. The key thing here is a lot of that is preventable. When I was a resident, we would have professors' rounds and we would literally spend an hour talking about whether to give a patient an aspirin or not. And the acute care role was put the patient in a room and come back in 3 days, and if they weren't dead, you had done a really good job. Well, I mean, there was an aspect of truth to that therapeutic nihilism, which was, for example, in the acute care setting at that point, we didn't have thrombolysis. We didn't want to feed a patient who was unable to safely swallow. We'd rather not put a catheter into someone and introduce bacteria and increase their chance of UTI or urosepsis. And so there was a basis for that. But fortunately, we've moved a lot beyond that. And so kind of drawing the broad boundary of this is a really big issue is important because it's now a treatable issue, a preventable issue to a large degree. What we're going to look at here is preventable or modifiable stroke risk factors. So first of all, the majority of stroke, about somewhere between 80 and 90% of stroke is ischemic, blocked blood vessel stroke. And as you can see, causes of ischemic stroke are heterogeneous. There could be cardioemboli, atrial fibrillation obviously being a big culprit there. There could be small vessel disease due to diabetes, high blood pressure, injuring the end blood vessels that have no collateral flow, and those cause small deep strokes that are typically identifiable by their clinical features. For example, paralysis of the face, arm, and leg without a sensory deficit, without a language impairment, and so forth. That's a pretty characteristic lacunar type of stroke. In most stroke databases, about a quarter to a third of stroke are unknown, and some of those are we just couldn't find a source, and in other cases, those are patients who have more than one potential source. For example, someone who has atrial fibrillation, diabetes, hypertension, and a high-grade carotid stenosis and has a stroke distal to that, well, what was their stroke cause? It's kind of hard to tell sometimes. Hemorrhages tend to be more deadly. Fortunately, a minority. We have very little in the way of prevention measures for bleeds. So this is a pretty typical image of a really bad ischemic stroke affecting the left middle cerebral territory. And so what you can see there is a large area of darkness affecting much of the left side of the brain. That patient is at high risk. That's someone who's already showing brain swelling, edema. There's mass effect, there's shift. That's someone who is aphasic, hemiplegic, drowsy, headed for herniation, might need a neurosurgeon to take off a third of their skull if they're young enough to potentially benefit from that life-saving intervention. Without surgery in a patient like that, the case mortality rate is about 75%. With surgery, it's about 25%. The issue, of course, is what's the salvage? Are those people going to be better? Are they going to be able to function? And that's iffy. That's certainly better if it's a younger person, and it's better if it's a non-dominant hemisphere, unlike that one. So this is small vessel, large vessel. This patient has got a occlusion of a large vessel injuring a large portion of the brain. Those are examples of intracranial hemorrhage. That is subarachnoid hemorrhage, so that's due to typically an aneurysm, but it could be due to endocarditis with an aneurysm distal to that. It could be vasculitis, but more typically than not, that is an aneurysmal rupture. Risk factors are having an aneurysm. Many of us do, actually. About 7% of people who come to autopsy have an unruptured aneurysm. Small ones are not dangerous. 2 to 3 millimeters, if that happens to show up, for example, on a scan that you've ordered on a headache patient or someone with some other condition, that's not something that needs worry. 7 or 8 millimeters, those are aneurysms that need intervention, even if they're completely asymptomatic. And these days, most of those, if at all possible, are treated with coiling, Dr. Gooding and his team, as opposed to clipping neurosurgery, because the results are better. Less invasive, less dissection, less brain edema, and as long as the aneurysm has a configuration that allows a little coil, or actually typically a number of coils, to be introduced via catheter from the groin, occluding the aneurysm, those people do better with that than surgical intervention. The other is a subdural. That's someone who probably fell and smacked their head. Of course, it could be someone who's on an anticoagulant who barely tapped their head, but that too is someone who needs surgery. There's a lot of mass effect. You can see the ventricle on this side is compressed over past the midline. It's very squished down, and that's a couple of centimeters thick, and that person is probably hemiparetic, drowsy, maybe seizing, and is likely to be fine or nearly fine with neurosurgical intervention. Not all hemorrhages have such good outcomes. So this one obviously had a dreary outcome because we've got sliced brain. Many hemorrhages, probably the large majority, are parenchymal hemorrhages, as you can see there. So there, high blood pressure commonly results in rupture of a tiny vessel that otherwise might occlude. So these same penetrating end vessels that can get occluded and cause a lacunar stroke can rupture in the wrong circumstances or right circumstances and cause a hemorrhage. Or potentially that could be someone who came in with an ischemic stroke, got TPA, and had a hemorrhagic transformation. Fortunately, with TPA, the occurrence of that sort of stroke that is turning into a bleed, is broadly, according to trial data, about 7%. Our data at Tri-City is about 4%. So luckily, that doesn't happen too often. Now, the key is that ischemic stroke, about a third of people die, a third are left disabled. With hemorrhages, about 50% die and about 90% are disabled. So we'd really like to be able to prevent those. And the key there is blood pressure management. In fact, I'm going to say that is the key for prevention of ischemic stroke as well. And I'll take you through the attributable risk for prevention of ischemic stroke. And you'll see that's the top thing. When the ER calls for a code stroke, the ER doctor typically has screened the patient. We often are pre-notified from the paramedics from the radio room. Hey, there's someone coming in. They had the abrupt onset of garbled speech. They can't keep their right arm up. Maybe they're a little drowsy. Those are clinical findings that imply a specific area of brain injury. And typically the neurologist can, based on the history and the exam, in this case more the exam, frequently define where in the brain the stroke is and perhaps the mechanism, in the sense that, for example, if someone has a dominant hemisphere stroke or non-dominant, they have a large vessel occlusion clinically, we're going to be looking for a carotid lesion, a carotid stenosis, or maybe a cardiac source. The various clinical syndromes are really defined by what blood vessel is involved. So in the left hemisphere, about 40% of blood flow to the brain, if not more, goes to the middle cerebral artery. So the most common strokes that occur in large vessels are middle cerebral, pretty equally right or left. In the left hemisphere, who here is left-handed? So we got a few. Everyone else has left hemisphere dominant for language, and of those people who are left-handed, at least half of you are left hemisphere dominant for language. So most of the time, a left hemispheric stroke is going to cause findings you can see there: right-sided weakness and numbness, garbled speech, perhaps visual loss to the right, depending on how far back into the brain. If it's in the visual area, that's going to be the typical finding. And if it involves frontal areas, then there'll be a looking towards the lesion, gaze preference towards the left. In the right hemisphere, which is usually not dominant for language, you can see the findings still include weakness, numbness, hemimotor, hemisensory, maybe visual, but instead of a language deficit, more typically, the person may have identifiable right-left confusion. Can you show me your right hand? I don't know. Neglect to the far side, which can also happen with left hemisphere lesions, but it's harder to tell because the person may not be able to talk to you. And they may have apraxia. Can you show me how to brush your teeth or something? Those sorts of features, those sorts of functions may be hindered. Brainstem strokes, posterior circulation strokes, account for a minority of overall strokes, and the symptomatology there, again, relates to the pathways and the circuitry that get involved. So people can have nausea, they can have vertigo. If they have a sensory or motor deficit, it's frequently crossed. So for example, someone might have numbness on the right side of the face. They may not be able to look to that side, but they may be numb or paralyzed on the opposite side of the body. And with that group of features, neurologists should be able to say, well, this is in the medulla, and it's within a couple of millimeters of this particular location. The most common source of that kind of a stroke, which would also typically give dizziness and hoarse voice and so forth, is a dissection or other occlusion of the vertebral artery picking off the most distal branch. So with that particular kind of a symptom, you can, or I can, or whoever's at the bedside, reasonably predict what happened. And then, of course, the next step is what are we going to do about it? TIAs, who here still remembers TIA as a neurologic event that lasted less than 24 hours? So that was the classic teaching way back when I was in training, and that's no longer thought to be the proper terminology or the proper definition. TIA is a transient neurologic event that's ischemic that leaves no damage. And so if you have ischemia, brain ischemia for 24 hours, there's damage. I don't care if I can't tell. That may be the limits of my exam. I don't care if I can't see it on an MRI necessarily, but typically a real TIA, that is those events that really clear up and have no injury, no brain cell death, they generally last less than 10 minutes and virtually always less than an hour, which actually kind of fits pretty sensibly with if one of your patients shows up to the emergency department, you sure don't want us to say, well, it's been 2 hours, let's wait another 20, 21, see what happens, because if it cleared up, hey, it was a TIA, and if it didn't, oh darn, you had a stroke. You expect, and I expect, that we're going to consider that patient as a code stroke candidate, and we're going to thrombolyse them if they're appropriate. So if we were to hold to that definition, not only would it be physiologically wrong, but it would miss the whole opportunity for treating people that we can actually help get quite a bit better. So most TIAs are quite brief. TIAs carry a risk or a predictive value of future stroke very comparable to someone who's already had a stroke. In other words, if someone has a stroke, they've already defined that there's something wrong, and they have a high future probability over the short term of having a stroke, and TIA patients have a very similar response. So what you can see here, this was from a trial at a Northern California Kaiser, and they looked at a number of patients who had come through the ER with a TIA diagnosis and what happened in the coming weeks and months. And what you can see there is, of those people that had stroke at the onset, a significant number of them went on to have additional stroke. If they had a TIA, 10.5% within 3 months had a stroke, and about half of that number had that stroke within the next couple of days, next several days, and then about 12% went on to have additional TIAs, and as you can see, a relatively small percent, a few percent over 90 days, that is, died. So we look at TIA as an indication of unstable brain, right? It's sort of like unstable angina of the brain. This is someone where we need to identify what's going on, because when the patient shows up and they're sitting there and they're feeling fine and they want to go home now because, hey, I'm no longer garbling my speech and my arm works great and I've got a golf game this afternoon or something, we need to educate them that in fact they're right on the cusp of having something bad happen, and at the time that they're in the emergency department, we can't necessarily tell what happened. I mean, we can tell some things. We can do a carotid ultrasound and validate that their vessel is fine, but I can't tell, for example, that they didn't have paroxysmal AFib an hour ago, and the risk of stroke from PAF is exactly or very close to the same as sustained fibrillation. So we need to know what's going on in that patient, and as a result, for those that have more than a very low risk, someone who has, for example, 30-year-old with numbness and tingling, well, their likelihood that that was a stroke or TIA is actually fairly small. They're much more likely, for example, to have had migraine, or one of the most common causes of a phone call to the UCSD stroke hotline when I was a resident, someone would call in the middle of the night and say, I'm kind of concerned I might be having a stroke, was carpal tunnel symptomatology. Someone's asleep, they wake up, their hands numb and tingly. So pure sensory events, people without the additional risk factors, hypertension and so forth, those patients may be able to safely be discharged, or we're in the process of trying to set up a TIA clinic within our practice that would allow the ER to send patients that are intermediate risk for immediate evaluation within 24 hours or less, be seen by neurology and kind of get the rest of their workup, if appropriate, done as an outpatient. This is a American Stroke Association list of attributable risk and kind of what the benefit of treating that is. Ultimately, we think that about a quarter of people with hypertension are adequately managed in the United States, and therefore probably close to half of stroke could be avoided if hypertension were adequately managed. In other words, about half of people with hypertension don't even know they have it. They're walking around and they're not necessarily having any symptoms. The other half may be on meds, but they're not really following through with you. I see people who come in for non-stroke or non-headache purposes to see me. They're coming in for numb feet or something like that. Their vitals in the office are 160, 170, and I say, yeah, it's usually like that, but we're just keeping an eye on it. And my response at that point usually is, I don't think that's a great idea. Let me call your primary and see what they would like me to start you on today, or at the very minimum, be monitoring your blood pressure at home, because in-office blood pressures may not be representative, but high blood pressure is really important. So that's the single most important risk factor for stroke prevention. All of these others are, of course, very important. Someone who is a smoker has about double the risk of a non-smoker, and after several years, their risk of stroke drops down to being a never smoker. So that's a pretty useful thing to tell a patient. It's not hopeless. It is hard. Yeah, I stopped smoking 30 times. I can do it anytime I want kind of response. Nevertheless, if they've come in with a TIA or a stroke, that's usually a teachable moment. Those people are kind of concerned, They don't want to end up dead or maybe worse in a nursing home, unable to take care of themselves. Atrial fibrillation, of course, is very important. Warfarin reduces risk of stroke in AFib patients by close to 70%, and I'll take you through some of the newer agents because those, I think, are transforming the way we should be looking at AFib management. Hyperlipidemia, statins are neuroprotective. There was a study done in Brazil of patients who presented with a stroke who were already on a statin, and they were randomized to continuation or discontinuation of their statin. And the patients who had their statins stopped had a 40% greater risk of dying in the coming 90 days. And their statin was only stopped for 3 days. It was restarted. So statins have a benefit far beyond lipid lowering in the context of cerebrovascular disease. So I mentioned earlier atrial fibrillation. When I was in training, the evidence for atrial fibrillation stroke risk reduction with warfarin was still being gathered. Now I don't think there's really any question whatsoever. But it turns out that an awful lot of people who have AFib, who otherwise warrant it, they have a CHAD score of 2 or greater, are not being anticoagulated with the, oh, well, they might fall, or they're old, or one or another, I'll say, excuse. Because in fact, the people that benefit the most are the old people. There was a study, it wasn't a study, I'm sorry, it was a model written up in, I believe it was the American Journal of Cardiology about 8 or 10 years ago, where the calculation was done of how many times an individual would have to fall to incur the risk of a subdural that would offset the benefit that would have been accrued by being on warfarin. It was about 300. If we can't prevent someone from falling 300 times, there's something seriously wrong, right? I mean, that patient could be in a nursing home, they could be monitored. There's a lot of things that we can do. So in people who are treated with warfarin with AFib, who warrant being on anticoagulants, the risk is vastly decreased, but keeping people with an INR between 2 and 3 is not always so easy. The research trials of the newer anticoagulants show time within therapeutic range, typically about 65% or so, 60 to 65%, occasionally a little higher in really tightly run academic trials. Community anticoagulation clinics get typically time in therapeutic range of about 52 to 55%. So our patients that we think are doing great, they're kind of bouncing around, and I think we all understand the issues with warfarin. Nevertheless, it clearly works. So at the very minimum, we need to be thinking warfarin for AFib patients who have additional risk factors. But luckily, we've got medications beyond rat poison. We've got some new medications that are available and improvements on across the board. So these studies were, in general, I'll take you through the individual agents in a moment, were in general started off as non-inferiority studies. In other words, to try to take a new medicine and show that it's at least as good or no worse than an established medicine that actually takes someone's risk of stroke back pretty close to that of the population that doesn't have AFib. That's a pretty big thing. And what we see with all of the newer agents is they work quickly. So you know, of course, that if we put someone on a vitamin K antagonist, warfarin, it's going to take days for their system to be fully anticoagulated, and if we stop their warfarin, it's going to take days for them to be no longer anticoagulated, and we can potentially reverse it a bit more quickly. We can give them fresh frozen, but it takes probably 12 hours and a lot of fluids to reverse them with that. We can give them factor concentrates that make their numbers normal, but it doesn't actually make their coagulation system normal. The new agents are active within 2 or 3 hours. They don't have any reversing agents. They generally have fairly short half-lives. They don't have monitoring, and some people look at that as an advantage, others as a disadvantage. They don't have interactions with foods, and that's huge. I remember a patient that I had treated probably 8 or 10 years ago. She was a young woman who had had a dissection, so taking it away from AFib, but into another circumstance where anticoagulation is typically used. Young woman had had a stroke related to a left carotid dissection, and I couldn't get her warfarin up to speed in like 5 days. It just wasn't budging. And then one day I walked into her hospital room, and she had it wasn't a little shot, it was a big shot of something really dark green, right? And it was wheatgrass juice, and she was just putting down shots of wheatgrass juice throughout the day, and she was just so replete with vitamin K, there was probably no dose of warfarin that was going to effectively anticoagulate her. The newer agents, it just wouldn't matter. So the new agents, apixaban, dabigatran, and rivaroxaban, are listed there. The first one to come out of the gate was dabigatran. It came out with a non-inferiority trial design and actually turned out to be considerably more effective than warfarin in preventing ischemic stroke, with a lower risk of hemorrhages in the brain, which is great because that's the biggest worry in people who have an anticoagulant aboard, who have warfarin aboard. If someone has an injury and they're bleeding from a limb, we can usually manage that. If they have GI bleeding, we can manage that. If they have bleeding in the brain and they come in with an intracranial hemorrhage of the sort that I showed you before, the fact that we can't reverse the drug is pointless, right? What we're seeing at that point is already the damage has been done, and we're just trying to mitigate the injury, but stopping the bleeding or not stopping the bleeding doesn't make a difference in outcomes. So here you can see the overalls, a little bit more detail here. The dabigatran 110 milligrams was non-inferior to warfarin in its clinical trial, whereas 150 twice a day was superior, and so the FDA did not approve 110 twice a day in the United States because they said, you've got a drug that's better, why would we give you an approval for something that's not better? So that is a dose available in Europe, but not here. The only approval, the only indication for that drug at this point in the United States is stroke prevention with AFib. Rivaroxaban, as you can see, was comparable to, but not dramatically better. Apixaban is substantially better. Intracranial hemorrhage rates are lessened with all of these agents, so all of them are improvements on warfarin, and it's a whole different discussion about in a patient who you want to put on a novel oral anticoagulant, which one to choose. But in fact, very broadly, it's hard to see a rationale for putting a patient on warfarin these days. Obviously, you could say, well, the drug costs are less. These new drugs are expensive. Warfarin is dirt cheap. But that doesn't include the costs of monitoring the patient. That doesn't include the costs of managing their intracranial hemorrhage or their 30% greater chance of having a stroke. And a stroke prevented, according to managed care guidelines, is worth at least $50,000 to them. So if you look at it from a value point of view, the newer agents actually look pretty darn good. If you look at warfarin and say, well, what if this drug were new to the market and someone were bringing this to the FDA, I don't think there's a chance in the world that warfarin would get an FDA approval at this point. Many patients don't warrant anticoagulants. In other words, if they don't have atrial fibrillation, the tool is really typically antiplatelet agents plus risk factor modification. So there are a number of studies looking at aspirin. This is a primary prevention study. This is the main study that indicates that aspirin is a risk-reducing drug in women for stroke, but actually didn't show a risk reduction in cardiac events, and this was with 100 milligrams every other day. In secondary prevention, a wide variety of doses have been looked at, and it turns out that there's really no dose-response curve for risk reduction of stroke. Aspirin at every dose reduces stroke risk by roughly 20%, but higher doses are less well tolerated. So that was looking at doses from 50 milligrams a day to 1,500, pretty wide dose range. In fact, there's one study, it was the Dutch TIA trial, where they looked at 30 milligrams a day and compared it to, I believe, 285, and there was no difference. So over a very wide range, low-dose aspirin is favored, and that in the United States is 50 to 325. Clopidogrel is now generic. It's a prodrug, so be aware that if you just blindly give clopidogrel to a patient and you don't test them for platelet aggregation or for the gene pathway that is necessary to turn it from a prodrug into an active drug, you don't actually know whether you're giving the patient anything useful. That wasn't done in the CAPRIE trial. It did show the benefit of clopidogrel. It was the pivotal trial that resulted in its FDA approval. Overall, that was a 0.5% absolute risk reduction of stroke. So it's not a home run drug compared to aspirin. It's an improvement on, but it's not a huge improvement on. On the other hand, there are people who can't tolerate aspirin, and in stroke world, clopidogrel is the drug that they should be on. If they can tolerate aspirin, Agrinox is a combination product that is roughly twice as effective as aspirin in risk reduction. This was from its pivotal trial. This trial was done when aspirin hadn't yet been proven, so there was a placebo arm. You can see that aspirin and extended-release dipyrimidol both were better than placebo. The combination product, now marketed as Agrinox, was roughly twice as effective. And so that's usually my preference for an antiplatelet regimen if someone needs antiplatelet, but it can have issues. About 20%, 30% of people who take that medicine will get headache that we can't get under control. It turns out, of course, headache is really common in the community, but dipyrimidol is a vasodilator. Most people get tachyphylaxis to vasodilator headache, but some don't. And so the strategy in those patients, if we're going to use that and the patient does get headache, is you can give the patient one at night for a week and a baby aspirin, or for that matter, a 325 in the morning. It's an FDA-approved initial dosing regimen. Don't keep the patient on that because that dose regimen of one a day has never been studied for effectiveness, so you really don't know whether you're helping the patient. But with that, patients who might otherwise have intolerable headache frequently can be gotten past that. And what I find is that if I educate the patient and their family, look, this is a lot better than aspirin, but it could give you a headache, just like Viagra or nitroglycerin could give you a headache, and it doesn't worry you if you get a headache in that circumstance. And we can manage the headache. You can take acetaminophen. It'll go away over a week or so. And the upside is it's a lot more effective than our other tools for you. Many people will deal with the headache and let it quit on its own. So we'll go past Groucho and talk about acute management. What has changed dramatically, of course, has been, first of all, the advent, now no longer new, of TPA for acute stroke care. We were involved at Tri-City in the initial trial. That was in 1991. And I actually came across the run tape of a woman that we treated 6 weeks before the trial started. She was 35 and had presented with acute stroke with non-dominant hemisphere event, middle cerebral artery occlusion confirmed on transcranial Doppler, and she had a dramatic response. And that really kicked off our enthusiasm in our stroke program many years ago. Well, it hasn't changed. You know, we still see, let's say, a Lazarus effect, dramatic on-the-table recovery in a significant number of people. So here's an example of someone who came in with symptom onset soon before they made it to the ER. The patient should, at this point, be rapidly assessed, and that typically happens initially in the field with the paramedics. We have pre-hospital notification of neurology, so paramedics will call and say, we think we've got a stroke. We have a pre-hospital screen that is county-wide. In this county, we have multiple stroke centers, and the paramedics are directed to take the patient to the closest stroke center. There are a couple of comprehensive centers. It's not clear yet what their role is going to be because, for example, at Tri-City, while we're a basic stroke center, we actually have Gold Plus. It's the highest certification that the American Stroke Association gives, and we have all of the features that a comprehensive center would have. In other words, we have neuroradiology that can do interventional measures, we have an ICU, we have neurohospitalists, all of the things that are necessary. So it's not clear that that's going to really change things too much countywide, and countywide we're looking at triage rules, so kind of stay tuned on how that will work. This is someone who I think warrants TPA. He has a INR on his warfarin that's subtherapeutic, so I think that kind of implies maybe what his stroke etiology was. His blood pressure is a little bit high. The threshold for managing with TPA is 185 systolic. but I'm sure with a little bit of a Tenolol or something we can bring him down, or just kind of be quiet around him for a few minutes and not stimulate him, and he'll be better. And so that patient gets oxygen, rapid screen. They get sent over for a non-contrast CT. Typically, neurology will be there right about that time to try to make a decision. We're having a pit stop approach that we're rolling out where patients are going to actually go bypassing the ER by and large and go from paramedic. They'll just stop in the ER so they can kind of get identified and someone can eyeball them, but continue on the paramedic gurney right to CT to cut out 5 or 10 minutes possibly. Because what we have is time is brain. In other words, every minute of lost perfusion is a couple of million neurons lost. So what we want to do is shorten the door to needle time as much as practical. We can't do very much about the onset to calling the paramedic time, except of course, educating the community and having you educate your patients that if they have sudden one-sided weakness, numbness, garbled speech, the typical stroke signs, that they shouldn't call me or you. 911, it's a very simple message. And that's the best way we've found to shorten the initial symptom to ER presentation time. And once the EMTs show up, they're very speedy, so they're not a delay at all. This patient goes off to CT, they should get TPA. That's just the bottom line. What we've seen is a steady uptick countrywide with the use of TPA and a steady improvement in our ability to deliver TPA to the right patients at Tri-Cities. So